educational webinar on pediatric nephrology and rare kidney diseases. Welcome from Marina Vivarelli. I'm a pediatric nephrologist working in Rome, in Italy. And today it's my great pleasure to introduce a topic which is, multidisciplinary, and that will have two speakers covering both congenital and immune-mediated thrombotic thrombocytopenic purpura. Our two speakers today are Bérengère Joly-Laffargue and Evelyn Seelow. Bérengère will be starting, followed by Evelyn, and I will give you a brief introduction about both of them so that we can then start the webinar without further ado. As always, there will be some poll questions, and all of the questions, both through the chat, will be done at the end. So you will have time to ask everything that you need to at the end of the webinar. So to pass on to the introductions, Bérengère Joly-Laffargue is an associate professor of hematology. She works in Paris at the Lariboisière hospital, and she also works at the French National Reference Laboratory for ADAMTS13 within the French Reference Center for Thrombotic Microangiopathies. So she's a practicing hematologist focusing with her research on both autoimmune and congenital forms of TTP, both in adults and in children, with a particular interest in TTP during pregnancy. Professor Evelyn Seelow instead is an adult nephrologist. She works at Charité, University Hospital in Berlin, and she is a leading expert for thrombotic microangiopathies and complement-mediated kidney diseases in Charité. She has also completed her postgraduate curriculum in rare kidney diseases of the ERKNet, and she is an active member of the ERKNet TMA working group, which I invite anyone who is interested in to join, as I'm one of the chairs, and we definitely need more interested and active members. So if there's anyone out there who is not yet a member and is interested in his or her profession to join this working group, we would be absolutely delighted. So without further ado, please, I turn it over to the speakers, starting with Bérengère Joly-Laffargue, and enjoy the webinar.
Thank you for your introduction. So hello everyone, I am very happy to have the opportunity to talk to you today about child-onset immune-mediated TTP. So we will begin with a poll question 1.
So I started the poll question. How many adult iTTP cases have you seen in your practice? And you have now 30 seconds. Okay, another 5 seconds. And I think everyone voted. Can you see the result?
So none of you have ever seen iTTP cases in your medical practice. 38% of you maximum 5 cases, 15% of you between 6 and 20 cases, and none of you more than 20 cases. Okay, so poll question 2, please.
So the poll question started.
So how many pediatric now iTTP cases have you seen in your practice? So none, 1 or 2, 3 to 5, or more than 5.
And under 10 seconds. Okay. And here's our results.
Yeah, so 40% of you have seen 1 or 2 cases, and 20% of you between 3 and 5 cases of iTTP in children. So this is a very rare disease. And now poll question 3, please. So which first-line therapy do you usually start in iTTP? So PEX and steroids and rituximab, PEX and steroids and rituximab and caplacizumab, or others?
For another 10 seconds. And here are the results.
Okay, so most of you use plasma exchange on steroids, and the other had rituximab, and only 21% of you the triplet was rituximab and cablasimab and PEX, and none of you other therapies. So we will, I will present you all the diagnosis, the epidemiology, and the treatment of iTTP in children during this webinar. So, defined by a microangiopathic hemolytic anemia, a thrombocytopenia of consumption, and ischemic multi-organ failure. It is known for its clinical diversity, and in children, the most common TMA syndromes are hemolytic uremic syndrome, which mainly affects the kidneys, and thrombocytopenic purpura, which often involves the brain. The differential diagnosis includes autoimmune hemolytic anemia, immune thrombocytopenic purpura, event syndrome, and malignant disease such as leukemia or lymphoma. Diagnosing secondary TMA can be especially complex and challenging, and in children or in adults. In physiologic condition, you have ultra-large von factor multimers, which are released from endothelial cells, which are cleaved by ADAMTS13 into smaller and less adhesive to platelets. In iTTP, because of the absence of ADAMTS13, congenital defect or immune-mediated defect with specific autoantibodies, these ultra-large von factor multimers circulate and they bind spontaneously to platelets, forming aggregates in small arteries and capillaries, and these aggregates become macrothrombi, leading to tissue ischemia, platelet consumption, and microangiopathic hemolytic anemia with schistocytes on the blood smear. We know that several factors are known to predispose to iTTP, including female gender, Black ethnicity, HLA-DR-B111, or obesity, and in addition, conditions that raise plasma VWF levels, such as inflammation, infection, or pregnancy, may act as triggers for acute episodes of both acquired or congenital TTP. If we focus on iTTP, so immune-mediated TTP, the autoimmune response against ADAMTS13 is polyclonal, and anti-ADAM13 IgG inhibits the proteolytic activity of the protease on VWF, and specific circulating immune complexes have also been reported. This mechanism contributes to a severe ADAMTS13 deficiency, and we have two types of autoantibodies which have been described, mainly neutralizing antibodies, which directly inhibit the catalytic site of ADAMTS13, and non-neutralizing antibodies, which form complexes with ADAMTS13 and accelerate its clearance. TTP is a rare hematologic disease with a prevalence of around 10 cases per million people, and an annual incidence of 1 to 2 new cases per million people. TTP is around twofold more frequent in women, and around half of all patients present with another clinical context, pre-existing or concomitant to TTP, and they are referred to non-idiopathic TTP. And the most frequent association include infections, autoimmune diseases, pregnancy, drugs, cancer, transplantation. And in contrast, we have 50% of all TTP cases which are idiopathic with no additional context associated. TTP has, it is a relapsing disease, and it is life-threatening with a high mortality rate if there is no treatment. And the first acute episode of TTP usually occur during adulthood, like you can see on the right of the slide, with around 90% of all TTP cases, and you have only 10% of all TTP cases which occur during during childhood or adolescence. TTP is mainly due to an autoimmune mechanism with autoantibodies against ADAMTS13. And if we take 100% of TTP cases, we have most of those cases who are immune-mediated and only 5% who are congenital. And if we focus on pediatric onset TTP, we have another distribution of this mechanism with around 1/3 of congenital TTP and 2/3 of autoimmune TTP. To illustrate this, we can see the data of the French TMA registry with our 25 years experience. We have around more than 1,300 pediatric onset TMA patients, and among them 115 cases of child onset TTP, so patients who have an activity less than 10% during the acute phase. And among them, we have 115 children. Among those children, we have 73 children who have high TTP with detectable anti-ADAMTS13 IgG at diagnosis and recovery of ADAMTS13 activity during remission, and 42 pediatric onset congenital TTP with documenting sequence variation on ADAMTS13 gene. The diagnosis workup for TMA includes complete blood count, platelet count, reticulocyte count, the blood smear, and the hemolysis test. For the differential diagnosis, we have to include coagulation tests, vitamin levels, direct antiglobulin test, and autoimmune screening, infection screening, and complement level. For the etiological workup, it is important to identify potential triggering factors and to perform pregnancy tests when appropriate, of course. And specific tests for TTP diagnosis is mandatory to confirm the diagnosis with, as a first-line test, the measurement of ADAMTS13 activity, which is less than 10% in TTP. And after, you have to measure the antibodies against ADAMTS13, and when appropriate, the molecular analysis of ADAMTS13 gene. Finally, assessment of target organ involvement should include brain MRI, electrolyte panel, renal function test, the cardiac evaluation, and liver evaluation too. And pre-transfusion testing should always be performed for this pathology. Clinical presentation of iTTP in children can be either idiopathic, like in adults, or it may occur in association with other clinical contexts, mainly autoimmune diseases and infection. The severity of organ ischemia ranges from isolated thrombocytopenia to multivisceral ischemia, and this is a relapse, and relapse may occur during the follow-up in children too. Children require the same therapeutic strategy as in adults, including plasma exchange, immunomodulation, and caplacizumab, and we will discuss this point in this presentation. In 2016, we reported a study in France with a French cohort of child onset iTTP with 45 children who were included in this study. And among them, 25 have an idiopathic TTP and 20 have a TTP associated with other conditions such as infection, autoimmune disorder, and less frequently transplantation, cancer, and other rare diseases. The sex ratio in this cohort was 2.5 females to 1 male, and the first episode occurred between 4 months to 17 years with a median age at the first TTP episode of 13 years. Idiopathic cases were more often seen in older children, while non-idiopathic cases were more frequent in younger children, especially under 10 years. During the first episode, fever was reported in 36% of cases and ischemic disorder in 64% of all cases, and ischemic complications were more often frequent in non-idiopathic TTP, and kidney involvement was also more common in these patients. All children presented by definition with a microangiopathic anemia, thrombocytopenia, and these hematologic parameters did not differ between idiopathic or non-idiopathic cases. Almost all idiopathic cases had anti-13 IgGs at diagnosis, and as a first-line treatment before the era of caplacizumab, patients were treated with a plasmide change or infusion of fresh frozen plasma. Around half of patients had additional rituximab, and the outcomes including 41 remission and 4 deaths. Finally, the study underlined a high misdiagnosis rate of 31% of cases, mainly due to limited awareness of TTP and the difficulty, of course, of distinguishing it from other TMA syndrome like HUS or atypical HUS or other autoimmune disease or malignant hemopathy. Interestingly, in the French cohort of child-onset iTTP, both phenotype and allele frequencies of HLA-DRB111 were significantly higher in the French cohort of child-onset TTP, represented with a red line on the slide, compared with healthy French individuals, represented with the blue area, and with the healthy Caucasian previously reported by Copo and collaborators with the red area on the figure. In contrast, there is no difference in phenotype and allele frequencies of HLA-DRB111 between our cohort of child-onset iTTP and the previously reported cohort of Caucasian adults with iTTP represented in green in this figure. In the US, Cohen and collaborators performed an analysis of adolescents with iTTP from 2009 to 2020. Those patients were aged between 10 and 21 years, and they reported a predominance of female patients with a median age at the first admission of 16 years. And in this cohort, 41 patients had a non-idiopathic form of TTP, and 21% experienced more than one acute episode during the follow-up, and thrombotic complications occurred in 15% of patients, and hemorrhagic complications in 29% of patients, and infection were diagnosed during hospitalization in 33% of all those patients. In iTTP, we have 3 therapeutic targets: ADAMTS13, anti-ADAM13 autoantibodies, and VWF, or the X with the binding of VWF and platelets. So frontline treatments consist of daily plasma exchange or plasma infusion, depending on the child's age, and in order to replace the missing ADAMTS13. Steroids are usually given as part of the initial treatments, and rituximab too for the immunomodulation in iTTP. And finally, caplacizumab is approved for adolescents aged of 12 years and older with a body weight at least of 40 kilos, and we will discuss this point in the next slides. In the acute phase of iTTP, treatment should be initiated promptly based on clinical suspicions and patient history, while working experts to discuss differential diagnosis of iTTP, including the cTTP. If there is a strong suspicion of iTTP, the therapeutic strategy as in adults should be applied. So this is a triplet regimen, including therapeutic plasma exchange if possible, immunosuppression with steroids and rituximab, and caplacizumab with dose adjustment in children as needed. Together, this treatment target the three key mechanisms of the disease, so severe ADAM13 deficiency, the production of autoantibodies, and excessive VWF platelet adhesion. Rituximab is used in iTTP in both adults and in children. In children, it has been used firstly for refractory iTTP with suboptimal response to first-line therapy for relapsing disease, or as a preemptive therapy in patients in clinical remission but with the monitoring of ADAM13 activity, they had an activity below 20%, and during the follow-up, and it is now mandatory to use preemptive rituximab to recover normal ADAM13 activity and to avoid clinical relapses. In France, since 2005, rituximab has been given to 32 children during the acute phase, 15 as a preemptive treatment for relapse, and 13 patients for clinical relapse. To date, there is no resistance to rituximab, but if it occurs, alternative immunosuppressive agents or anti-CD20 agents should be considered in those patients. Caplacizumab, so an antibody which interacts between the GP1B of the platelets and the VWF domain A1 of VWF, is approved for the treatment of iTTP in adults and now in adolescents age of 12 years and older, of course, and who weigh at least 40 kilograms. Taylor and colleagues from the UK reported its use in 16 patients under 18 years from the UK TTP registry, including 4 patients younger than 12, and for those weighing less than 40 kilograms, so 3 patients, caplacizumab was given at a dose of 5 milligrams once daily. In the French court, caplacizumab was used in 12 patients too, under 18, including 3 patients younger than 12, and similarly for those under 40 kilograms, so 3 patients, the dose was of 5 milligrams once daily. So the use of caplacizumab in pediatric iTTP, so less than 40 cases were reported worldwide, so it is approved for children after 12 years, and for children less than 12 years or 40 kilograms, it is recommended to have a dose reduction of 5 milligrams and use a compassionate access for this drug. Cohen and colleagues from the US analyzed adolescent patients with iTTP, and they identified 99 patients and 123 hospitalizations for TTP treatment, and over 90% of admission for iTTP were treated with systematic steroids in addition to plasma exchange. Rituximab was used in 50% of cases, and 20 patients received additional immunosuppressive agents like cyclophosphamide in 11% of patients, and only 4% of cases received acetylcysteine, and caplacizumab was reported in only 2 cases because it is recently available, and there is no difference in the study with other treatment strategies. Another point which is very important for those patients with iTTP with an onset during the childhood is among patients who are survivors after a TTP episode. We reported in the French cohort that the first relapse occurred at variable times, so with a median of about 1 year after the first episode, but relapses are frequent, more frequent in idiopathic iTTP, and during the long-term follow-up, we reported 10 relapses, and 7 children received preemptive rituximab because their ADAM13 dropped below 20% of activity. And our study also highlights the presence of biological autoimmunity in 7 patients and clinical autoimmunity in 2 patients. And 2 children experienced psychophysical sequelae after the TTP episode. So it is very important in those children to have a regular medical follow-up, a close monitoring of ADAM13 activity during the follow-up, an autoimmune workup, and to follow those patients with the transition from pediatric to adult care and pregnancy management during adulthood. Relapse-free survival was expressed in 45 patients with child-onset iTTP during the follow-up, and compared between idiopathic and non-idiopathic TTP and overall survival patients. The relapse-free survival rate decreased until the 4th year after the first episode to reach a stable value of 60%, and the higher relapse rate was associated with both an idiopathic initial presentation and the autoimmune feature of TTP. In the US, Cohen and collaborators reported a median time from initial acquired TTP admission to relapse of 1 month, of 33 days, and there was no significant difference between the relapse and non-relapse group in patient demographics, underlying comorbidities, or diagnosis time frame. Another point which is very important for those patients is the patient who have a history of iTTP, and what those children become women, they have to be monitored for the next pregnancy if possible, because the approach will depend on ADAM13 activity before conception, of course, if possible. So we know that the follow-up of iTTP patients reported an overall relapse risk of around 20%, which can occur independently of pregnancy or other underlying conditions. Therefore, lifelong monitoring is recommended, and for pregnancy, we know that measuring ADAM13 activity before conception has important prognostic value, because patients who start pregnancy with normal ADAM13 activity usually maintain it throughout pregnancy. And in contrast, starting pregnancy with low or undetectable ADAM13 activity is usually associated with a high risk of relapse, while normal or preemptively corrected activity using rituximab when possible strongly reduce the likelihood of TTP relapse. So in patients with an activity below 20%, pregnancy is not recommended, and immunosuppressive treatment is discussed. We can, if possible, wait for a persistent normalization of ADAM13 activity before pregnancy. When the activity is below 20% and the patient is pregnant, we have to consider immunosuppressive treatments, biological monitoring, a close monitoring during the first 2 trimesters, and after in the 3rd trimester, an antenatal monitoring and a scheduled delivery. And when the activity is over 50%, we have to continue the biological monitoring and antenatal monitoring. And if unfortunately a clinical relapse occurs, we have to treat it with that might change, and we will discuss immunosuppressive treatments. And with biological relapse occur during the pregnancy, we sometimes have to consider immunosuppressive treatments and schedule delivery. The monitoring of pregnancy is warranted with complete blood count, reticulocytes during pregnancy, hemolysis panel, the liver function, the renal function every month, and ADAM13 activity once a month and twice a month during the 3rd trimester. Those patients need a close maternal and fetal monitoring, and at delivery, we can propose a placental histology, hematological panel, and MTR13 activity of the newborn if necessary. And in case of intrauterine fetal restriction, placental and fetal histology, fetal DNA analysis, and the consent required. So this is a challenging disease because we need to follow our patient. If this is a relapsing disease, we need to, for long-term monitoring of ADAM13 activity, to screen early signs of relapses and risk of there is a known risk of long-term sequelae with fatigue, memory loss, and the psychosocial impact. The challenges are the diagnosis, to reduce the diagnosis delay due to the rarity of this rare entity, the need for pediatric specific treatments to be collected in registry, to monitor the autoimmunity and the comorbidity, and to screen HLA and genetic predisposition if possible, and to follow our patient for the transition with adults, and especially during pregnancy. In conclusion, pediatric onset iTTP, it is a very rare entity within a rare disease. There is significant improvement in clinical, biological, and therapeutic management since the years 2000. And there is a similar clinical and biological features and treatment strategy now with a triplet regimen as an adult onset iTTP. The management and long-term follow-up recommendations are usually have been recently updated, and this is we have emerging therapies with immunomodulators, nanobody like placizumab, and maybe one day in iTTP recombinant MTR13. It is important to follow our patient with the transition to adults, to give them a psychosocial support and pregnancy planning, and research perspective are very challenging with pediatric registries, clinical trials, and scientific research. And the key objective of all this work is to optimize long-term outcomes and improve quality of life of patients with pediatric onset iTTP. So I thank the ERKNet for the kind invitation and also the French Reference Center for TMA, and I thank you for your attention.
Thank you very much. And now over to Professor Evelyn Seelow.
Thank you very much for the invitation. I hope you can already see my screen.
Yes.
Okay, so my topic will be congenital TTP, and I want to start with a poll question. How many cTTP cases have you seen in your practice so far? Can you already see the poll?
Yes, I started it. And you have another 20 seconds. Okay, I think everyone voted.
Okay, I cannot see the results, so maybe you can report.
Yeah, I can do that for you. So 83% of respondents say that they have never seen a congenital TTP case, while 13% have seen one and 6% have seen 2 or 3. Nobody has ever seen more than 3 within the group.
Okay, thank you. I will continue with my talk. So indeed, it's very rare, even rarer than immune-mediated TTP. You've seen this slide before. So we are talking about these 5% of patients with TTP who have a congenital background. And in adulthood, it's even rarer. So about 2 out of 100 patients will have congenital TTP. So this is a congenital deficiency of the enzyme ADAMTS13. It's autosomal recessive. The prevalence is less than 1 per million. Yeah, you may know the synonym Upsher-Schulman syndrome. And the pathogenesis is that in the absence of the ADAMTS13 enzyme, metalloprotease that cleaves the ultra-large von Willebrand multimeres, there is formation of microthrombi that lead to occlusive microvascular thrombosis, which results in tissue ischemia, thrombocytopenia due to consumption, and microangiopathic hemolytic anemia. There are several disease mutations that are known so far. In about 60% of cases, there's a compound heterozygous background. And I want to point out just 2 mutations. There's the most frequent disease mutation, a duplication in exon 29, which usually, when it is in a homozygous state, is associated with a very low ADAMTS13 activity and also an early onset. And there's in exon 24, there's a disease mutation, a missense mutation that is related to late disease onset, especially during pregnancy, because there is some residual ADAMTS13 function, about 5 to 10%. So this is also from the global hereditary TTP registry. They analyzed whether the residual ADAMTS13 activity is related to disease onset. Yes, this is the case. So if the ADAMTS13 activity is below detection level, usually there's a very early onset during the first year of age, but still there are some patients without residual activity that have late onset disease during adulthood. So what is the clinical picture? This really also depends on the disease onset. During the neonatal period, it's a severe jaundice that usually also warrants exchange transfusions. It can manifest as isolated thrombocytopenia with bleeding and purpura. You can have the symptoms of tissue ischemia, such as stroke, cardiac dysfunction, gastrointestinal symptoms. In young adults, especially young male adults, there is triggering by alcohol consumption, which leads to severe gastrointestinal symptoms and microangiopathic hemolytic anemia. And during pregnancy, there is a high rate of fetal losses, but a pregnant patient can also present with thrombocytopenia, especially in the 3rd trimester, and also symptoms such as stroke. Triggers include pregnancy, but also infection, vaccination, and trauma, as well as alcohol and some medications such as desmopressin that increases the von Willebrand multimer release at the endothelium. Here I want to share some key findings from the International cTTP registry. There are the patients included usually had disease onset at the age of 4.5 years, but the clinical diagnosis was usually made a lot later at the age of 16. And the type of manifestations were usually thromboembolic events in about 30% of patients, especially stroke, but also myocardial infarction and transient ischemic attack. There are also other neurologic disorders that can occur, such as epileptic seizure. And I want to point out that renal insufficiency is quite frequent, especially in adult patients, some even with progressive kidney failure and need for renal replacement therapy. And there are a lot of patients, about 11%, that were on prophylactic treatment and have suffered transfusion-related viral infections such as hepatitis B or C. So it's important that you keep your patients vaccinated to prevent infection. This is also a very important figure from the registry. The lifetime occurrence of arterial thromboembolic events is high. So by the age of 50, almost half of the patients have suffered significant arterial thromboembolic events such as stroke, which also underlines the necessity for prophylactic treatment. Neuropsychiatric symptoms may be long-term results from TTP, and those include headaches, poor concentration, cognitive dysfunction, depression, among other things. So how do we, what are the treatment recommendations at the moment? So depending on availability, there's fresh frozen plasma, which can provide functional ADAMTS13, and in patient in remission, you can apply prophylactic therapy. It's 10 to 15 milliliters per kilogram every 1 to 3 weeks. And for recombinant ADAMTS13, it's 40 units per kilogram, also bi-weekly. In flare-up, you need daily therapy until 2 days after the acute TTP has resolved. In refractory cases, you can increase the dose and the frequency. This is expert opinion. And if there's a trigger situation that you can plan for, such as elective surgery, the recommendation is to give preemptive therapy 1 day before the procedure and another dose within 24 hours after the procedure. For pregnancy, there are also expert recommendations that I've not included. I think in the case of pregnancy, it's always important to also contact experts and to follow it up with experts. So I want to show you the data of the phase 3 study, which led to FDA and also EMA approval of recombinant ADAMTS13. Patients with congenital TTP were enrolled, a little over 40 patients in total. The study included patients on prophylactic therapy, but also patients with on-demand therapy who only receive treatment when there's flare-up. And the design was as follows, that they did a crossover design. For the first 6 months, the patients received a standard therapy or recombinant ADAMTS13, and then they switched over to the other group. And this is a demonstration of the pharmacokinetics. So with fresh frozen plasma, the ADAMTS13 level only rises to about 20 to 25% and drops below 10% activity within 3 days. For the recombinant ADAMTS13, the ADAMTS13 activity levels normalize, and it takes about 7 days for them to drop below the 10% activity threshold. So most likely patients are protected for a longer period of time. I mean, it was only about 40 patients, and there were not a lot of events, but the pre-specified TTP manifestations such as thrombocytopenia, elevated LDH level as a marker for hemolysis, the creatinine level, neurologic symptoms, and also abdominal pain were less in the ADAMTS13 group. The composite TTP endpoint was also significant. So this led to FDA and EMA approval of recombinant ADAMTS13, and there has been an update of recommendations in the ISTH guidelines that cTTP patients that are in remission should obtain prophylaxis, and if recombinant ADAMTS13 is available, there's a recommendation to use the recombinant enzyme. Here it's actually the same information. On the left-hand side, the 2020 recommendations, and on the right-hand side, the updated recommendations. So there has been a change that people who are in remission should be offered prophylactic treatment, and if recombinant ADAMTS13 is available, this should be preferred over fresh frozen plasma. And this is also a very recent application from Bérangère. Thank you, Bérangère. It's a head of print. So that's from the French TTP registry. And you can see that patients without treatment, and this is about relapse-free survival, within 10 years' time, oftentimes suffer from TTP events, whereas patients on prophylaxis have less events. And the recombinant ADAMTS13 treated group, there's only a follow-up of about 4 years, so there's so far no significant difference between fresh frozen plasma and recombinant ADAMTS13, but with a longer period of observation, this may prove superior to fresh frozen plasma. So what about pregnancy? Pregnancy is a potent trigger for TTP manifestation because there's a higher von Willebrand multimer level, and this shows how dangerous pregnancy can be when you're not unaware of the cTTP diagnosis. Patients who where you know that there's a cTTP and who are on prophylactic treatment, usually it is possible to have a safe pregnancy with a normal birth. But in patients where the diagnosis is not known and where the patients do not obtain fresh frozen plasma, over 50% of these patients suffer fetal death, which also underlines that all pregnant patients should be on treatment. And now I want to share, with his permission, a case with you. This is a patient in my outpatient clinic. He, at the time of his first TTP manifestation, he was 46 years of age, and he had an acute abdomen. So he presented in an emergency room with severe pain. On clinical exam, there was a scleral icterus, and the doctors quickly diagnosed an acute abdomen due to mechanical bowel obstruction. So his prior medical history up to that date was that he was suffering from recurrent thrombocytopenia of unknown origin, and it was classified as immune thrombocytopenia most likely, or an alternative platelet disorder. So this was an acute setting. There was not a lot of time. More deep history taking would have revealed that already during the neonatal period, he had suffered severe jaundice that needed to be treated with exchange transfusion, and that during his childhood he had recurrent episodes of purpura and thrombocytopenia triggered by infections. Back then they were treated with steroids and immunoglobulins, and they resolved. And that during his adolescence, after a party with heavy alcohol consumptions, he suffered a severe episode of hemolytic anemia that also required blood transfusions. And he shared his medical reports with me. Some were handwritten, some were typed, and that was an episode when he was 1 year of age. And already here you can see the hallmarks of TMA. He had icterus, he had hematomas, he had purpura. So already here at 1 year of age, there was suspicion for thrombotic microangiopathy. So back to the ER, we have this 46-year-old patient. There was emergency lab tests, and I just share with you the most prominent values. He had a severe thrombocytopenia, 35,000. He was a little anemic. He had high bilirubin levels and already kidney dysfunction, and the dipstick was positive for blood and protein. So he was transferred to the operating room, and upon operation and surgery, it was discovered that the mechanical obstruction was due to extensive bleeding into the small intestine wall. He required resection of small bowel. Fortunately, they were able to re-anastomose it, and the pathology revealed hemorrhagic infarction of the ileum. Because of the low platelet level, the surgeons asked hemostasiologists to give advice on bleeding management. So to reduce the bleeding, he received 2 thrombocyte concentrates and also tranexamic acid and desmopressin. So after the surgery, this patient developed 2 subsequent seizures, which required intubation and mechanical ventilation. He suffered from progressive kidney dysfunction, which required dialysis. He also developed atrial fibrillation and hyperactive delirium. And luckily, the wounds healed well. I was not able to discover whether he received fresh plasma. That might have helped. And the kidneys recovered partially, and before the workup for his thrombocytopenia had been completed, he was transferred to rehabilitation. So the diagnostic test for ADAMTS13 activity was sent out, but was not known at the time of the rehab. So he showed signs of TTP with a severe and diminished ADAMTS13 activity below 5%. The antigen was also very low, and there was no inhibitor, no autoantibody detectable. So during the rehabilitation, he also developed 1 short episode of aphasia, so most likely a transitory ischemic attack. Upon his discharge, this diagnostic test was discovered, and he was advised to seek help at my outpatient clinic. So that's what he did. And we admitted him to our hospital, put him on fresh plasma infusions, and sent out genetic testing. And he was found to be compound heterozygous. And he has 1 variant that is so far unknown, and he has the very frequent duplication, the most frequent variant, pathogenic variant in Europe. So the final diagnosis of this patient is a cTTP with a flare-up that led to gastrointestinal, renal, cardiac, and cerebral involvement. The trigger is unknown, possibly alcohol, although he did not consume a lot. and the aggravating factor in his case were the platelet infusion, the desmopressin, and also the trauma. And it is important to do a screening for organ involvement. He has residual CKD stage 2 at the moment because of his episode of atrial fibrillation and also elevated troponin levels. We performed a cardiac MRI, which showed focal late enhancement that is probably a TTP manifestation, and this cerebral MRI also revealed multiple microbleeds. So we put him on prophylactic treatment, initially with fresh frozen plasma, every 2 to 4 weeks in the beginning, because he had a very, very long phase without TTP manifestations. He would have preferred on-demand therapy, but upon extension of the infusion interval, there was thrombocytopenia and haptoglobin consumption. So now he's on permanent prophylactic treatment, and we were able since 2024 to offer a recombinant ADAMTS13, initially as compassionate use, and now we can prescribe it. Yes, and currently we want to transfer him to home care because he has a long way to our outpatient clinic. So I want to show you what has been reached. Last year there was the 100th year of TTP research. So in 1924 there was the first case that was described by Moscovitch, and in 1960 there was the first case described by Schulman, where a hereditary background was suspected, and in the late 1970s, there was the second hereditary case described by Upshaw, and that's actually when my patient was born. So back then, the treating doctors were not able to really know the disease and treat it accordingly. And much later, in the early 90s, plasma exchange and plasma infusion was discovered as a potential treatment, and in the early 2000s, that's when ADAMTS13 was characterized. And shortly before my patient presented to the outpatient clinic, that's when recombinant ADAMTS13 was generated, and shortly after he presented, it was made available. So he was very lucky not to receive fresh plasma for years and years. So I want to summarize that cTTP can present in neonates, early childhood, but also in adults. It is often misdiagnosed as immune thrombocytopenia. Over 50% of cTTP patients suffer a significant arterial thromboembolic event by the age of 50. And there is also depression and cognitive impairment as a long-term consequence of cTTP. This underlines that prophylactic treatment should be favored over on-demand therapy. There is a significant transfusion-related viral infection in patients on a long-term prophylactic treatment with fresh frozen plasma. So if available, recombinant ADAMTS13 should be favored over fresh frozen plasma. And in adulthood, cTTP often manifests during pregnancy. And these women have a high risk for fetal losses and flare-ups. Therefore, all pregnant patients should be on prophylactic treatment. Thank you very much. It's very rare, so if you have the suspicion for such a case, don't hesitate to contact an expert. There's also a contact list on the ERKNet website, and I'm always happy to answer questions. And this leads to the last slide with the upcoming webinars. Thank you very much.
Thank you both to Bérengère and Evelyn. This was really, really interesting. Unfortunately, the hour is up. I was trying to see if there were any questions on the chat. I don't think there are. There is time for just one quick question if anyone from the webinar wants to type it in the chat. I wanted to ask a really naive question that came to me as a completely non-expert and very ignorant nephrologist. I was interested to know, to see that for congenital TTP, you use recombinant ADAMTS13, and for acquired TTP, use caplacizumab. And I was curious, I understand vaguely why, but I was curious if you could give me a bit of a more clear idea of why this is the case, because I think this is something that perhaps for nephrologists that are like me, not experts, could be an interesting thing, because I tended kind of to think, oh, you know, there's caplacizumab and it's a new thing for TTP. But instead, I have now understood that for congenital forms, recombinant ADAMTS13 is the way to go. If you can just quickly comment on that, I think that would be really useful for everyone.
You want to comment, Bérengère?
I will comment just for the CAPLA and after you with the recombinant, if you agree. So for the caplacizumab, I know it is a nanobody, bivalent nanobody that specifically targets the A1 domain of VWF, and it blocks the interaction with the GP1B on the platelets, and it is used in approval for iTTP, and it works correctly in iTTP, and there is no indication in congenital TTP, because patients need, of course, ADAMTS13, and it works very well. So there is no place with other drugs, but with a mechanistic, with a basic science, it could be interesting, but it's not used.
Okay.
Yeah, so congenital TTP is an enzyme deficiency, so it makes sense to replace the enzyme. Caplacizumab is bridging. It's a bridging to recovery of ADAMTS13 function, and because in congenital TTP it will never recover, it does not make sense to apply caplacizumab indefinitely.
Right, so you could use it acutely to sort of get rid of the thrombi and bring up the platelets, but then you need to give recombinant ADAMTS13.
Yes.
Okay, perfect. Okay, well, I think we've used up all our time. So really, thank you very much to both of our excellent speakers, Joly-Laffargue and Evelyn Seelow, and see you on September 16th for the membranous nephropathy. Have a lovely afternoon to everyone who has joined us, and thank you very much to our speakers.
Thank you very much for the invitation.
Thank you.
Bye-bye.
Bye.